A 75-year-old gentleman was admitted to the ICU with cardiogenic shock secondary to myocardial infarction. The patient underwent emergent left heart cath and impella device placement for LV support. He was, of course, intubated on multiple vasopressors. On day 3, he remained intubated, no signs of fluid overload. Blood sugar values were mostly less than 180. Labs showed evidence of acute kidney injury, but no significant electrolyte disturbances with adequate urine output. He was requiring 2 vasopressors instead of 4, and his impella support was down to P5. As a side note, if you want to learn more about impella device, I made a video about it and the link to that video is in the description field. On day 3, the cardiologist asked us if we can start some nutrition in this patient or not. Hi everyone, today I'm going to teach you exactly how to respond to such a request, how to order nutrition in critically ill patients, how to monitor and manage its possible complications step by step without any help from the hospital dietitian or nutritionist. So if you are taking care of critically ill patients, you will love this video. Keep watching. There are 6 questions we need to ask ourselves every time we are thinking about initiating nutrition in critically ill patients. Is it the right time to start nutrition? And if yes, then what type of nutrition should be used? Is there any contraindication to the chosen type of nutrition? How much of the chosen nutrition and free water needed to be given to the patient? And how to initiate the nutrition, and finally, how to monitor the nutrition. Let's start with the first question. Is it the right time to start nutrition? It is a well-established practice nowadays that enteral nutrition, enteral here means through the gut, should be initiated within 48 to 72 hours of admission as long as there is no contraindication. Please do not think of parenteral nutrition unless the patient has been in PO for 1 to 2 weeks with persistent contraindication to start enteral nutrition. Parenteral here means to bypass the gut and administer the nutrition directly into the blood. So start enteral nutrition within 2 to 3 days of admission, not right away, and don't think of parenteral nutrition during at least the first 7 days. Don't worry, your patient will not starve to death. Back to our case, it's day 3 since admission and we felt at the time it was an appropriate time to start nutrition. Now, how about the second question? What is the best type of nutrition should we use in our critically ill patient? As we just mentioned, nutrition in critically ill patients can be either administered through the gut enteral route by giving a tube feed through a nasogastric tube or orogastric tube or a PEG tube. Or it can be administered directly into the blood, parenteral route, like TPN, total parenteral nutrition, which requires a central venous access, or PPN, peripheral parenteral nutrition, which requires a peripheral venous access. As you know by now, we almost always pick enteral nutrition over parenteral nutrition unless there are 1 or more absolute contraindications to use enteral nutrition that persists for at least 7 to 14 days. It is clear that we had picked enteral nutrition in our case, but was there any contraindication in our patient at the time to start enteral nutrition? That brings us to the third question. Is there any contraindication to start the chosen nutrition, here enteral nutrition? So let's go over the contraindications to initiate enteral nutrition in critically ill patients. First, hemodynamic instability, like shock states where the patient typically requires multiple vasopressor support. So do not initiate tube feeds until the patient becomes more stable. And by stable here, I don't necessarily mean to be completely off vasopressors, but rather to look at the trend of the numbers, not the number themselves. Let's say there was a patient who was requiring 3 vasopressors and now he's requiring a single vasopressor. The patient is definitely becoming more stable despite he's still in a single vasopressor. Then I may go ahead and start a nutrition and not necessarily wait until he is completely off vasopressors. So please always look at the trend. Second contraindication, severe volume depletion. Make sure your patient has been adequately resuscitated with IV fluid before initiating any kind of nutrition. In real life practice, there is no need to worry much about this, as by the time you start thinking about nutrition, the patient should have been resuscitated adequately with IV fluid. Third contraindication is bowel obstructions or severe ileus. Here, usually wait until this issue resolves. In post-operative patients, we always consult with the primary surgeon before initiating any kind of nutrition. Upper gastrointestinal bleeding. Of course, here the patient should remain in PO until cleared by the gastroenterologist to start feeding. Ischemic bowel or any kind of acute abdomen that they need emergent surgical consult, not nutrition at the point. Intractable vomiting or diarrhea. We wait until these issues are under control. And finally, high output fistula. Notice here that lack of bowel sounds is not a contraindication to start tube feed. Same applies to the patient flat position. Again, being flat is not a contraindication to initiate tube feeding. Acute pancreatitis is not a contraindication to start enteral nutrition. Also, using paralytics is not a contraindication to start enteral nutrition. These paralytics work on skeletal muscles, not smooth muscles, which are responsible for peristalsis. Based on this, was there any contraindication to start enteral nutrition in our case? The only possible contraindication was the hemodynamic stability issue. Was our patient stable enough to start enteral nutrition? If we did not look at the trend of his hemodynamics, we would have said he's not stable to start nutrition. But as we just discussed, based on the trend at the time, he was requiring fewer vasopressors and less impellar support on day 3 compared to admission. We could have gone either way. We could have waited until he's more stable, and we could have considered him stable enough to start enteral nutrition, based of course on his hemodynamics trends and his constant improvement. And this is a perfect example of real-life clinical scenarios where most cases are not in the clear-cut zone. We will always need our clinical judgment to decide. At the time, in our case, we decided after consulting with the cardiologist to go ahead and start enteral nutrition through the orogastric tube that was already in place. So in our case, it was an appropriate time to start nutrition. We picked enteral nutrition and there was no contraindication to start the enteral nutrition. But wait, is it enough to put an order saying start tube feeds or enteral nutrition? The nurse will immediately ask you what kind of tube feeding you want to start. So after we pick enteral nutrition, we still need to specify what kind of tube feeding we will use in our patient. It's a perfect time to introduce you to the most commonly used types of tube feeds formulas and their specific indications. The first type we're going to talk about is the standard formulas. These are the most commonly used formulas. Their nutrient composition is meant to match that recommended for healthy individuals as long as there was no strong malabsorptive or maldigestive issues. They are the most commonly used formulas and the one to pick in most cases if they are available at your facility. Examples of these formulas are Ensure, Isosource, Impact, and Osmolite. Now, some of the standard formulas are calorie dense, which means they are concentrated to provide 1.5 to 2 kilocalories per meal compared to the non-concentrated, in which they provide 1 kilocalorie per meal. Usually we use these calorie dense in fluid overload cases. The second type we're going to talk about is the fiber supplemented formulas. These are simply standard formulas supplied with fibers. They are helpful with those having diarrhea or bowel movement irregularities. A big example of this formula is Jeberi. So if your patient is suffering from diarrhea, the fiber supplemented formula will be a good choice. The third type is the elemental and semi-elemental formula. These formulas contain partially or completely hydrolyzed nutrients so they can be easily absorbed. They are used with conditions of maldigestion or malabsorptions. Examples of this formula are Peptamen, Alitrac, and Crucial. So if your patient suffering from malabsorptions, then think of these formulas. Remember, this type of formula is much more expensive compared to the standard formulas. The fourth type is the blenderized formulas or real food formulas. These formulas have not been used in inpatient settings as far as I can tell. Just be aware of this type as they may become available for inpatient use in the future. The fifth type is the disease-specific formula, and this includes the following. Diabetic formula. From its name, this formula is designed for diabetic patients. They contain 40% less carbohydrates. The most commonly used diabetic formula brand is Glucerna. It's important to mention that being diabetic does not necessarily mean you should be on this formula. It should be reserved to only those with difficult to control blood sugar. Other Otherwise, standard formula can be just fine for diabetic patients. Renal formulas. Again, this formula designed for renal patients. They are lower on protein, calorically dense, and have lower levels of potassium, magnesium, and phosphorus when compared to standard formulas. The most commonly used renal formula brand is Nipro. Again, this formula is not for all renal patients. Use this formula only if there is persistent hyperkalemia, hypermagnesemia, or hyperphosphatemia. So if there's no significant electrolyte disturbances, the standard formula would be just fine. Renal replacement therapy or dialysis, whether continuous veno-venous hemodialysis, CVVHD, or intermittent, does not require renal formulas unless there are significant electrolyte disturbances. Also, these patients typically do not require fluid restriction and have higher protein requirements. So next time, don't jump to renal formula just because the patient has renal failure, whether acute or chronic. Look at their electrolytes. Hepatic formulas. This formula offers increased amount of branched chain amino acids but lower total proteins. They are low in fluids and sodium. An example of this type is NutriHep formula. Again, these formulas should only be used for those with advanced liver disease with hepatic encephalopathy that is refractory to drug therapy and who are unable to tolerate standard protein intakes without the precipitation of hepatic encephalopathy. Otherwise, standard formula would work just fine for most liver disease patients. Pulmonary formula. This formula is mainly designed for COPD patients with limited respiratory reserve. An example of this formula is Pulmocare brand, which contain high-calorie, modified carbohydrate and fat enteral formula that may help reduce diet-induced carbon dioxide production. There is really no strong evidence that support their use, but again, if you have a patient with severe COPD and poor respiratory reserve, think of this formula, Pulmocare. These are the most commonly used types of formulas used currently in clinical practice. So please make sure to familiarize yourself with the available types and brands at your facility. Now, based on these types, what kind of tube feeding would be the most appropriate for our case, our patient? Standard formula or standard formula supplemented with fibers, elemental or semi-elemental formulas, or one of the disease-specific formulas, diabetic, renal, hepatic, or pulmonary. What do you think? Now take this from me. Whatever formula you pick initially, it should be okay even if we don't pick the most appropriate formula. Notice that I'm using more or less appropriate term instead of right and wrong here, because any formula we pick should provide nutrition to our patients. It is just a matter of how much that formula would meet our patient needs. Now, the smartest thing to do if we are not sure what formula to pick or we are too tired to think is to pick a standard formula regardless. Of course, we will look much smarter if we pick the most appropriate formula from the get-go. Now back to our patients. Which one of the following formulas would be more appropriate as we just mentioned? So standard formula, this formula is almost always appropriate regardless. Our patient really did not have any fluid overload to think about calorically dense standard formulas. Now, standard formulas supplemented with fibers, our patient really did not have any bowel irregularity issue. He did not have any diarrhea, but this still can be considered appropriate to, especially if the standard formula was not available at the time. Now, elemental or semi-elemental formulas, our patient did not have any maldigestive or malabsorptive issues. How about the disease-specific formulas? Now, diabetic formula, our patient blood sugar was adequately controlled, so this formula would be less appropriate to our patient. Renal formula, despite that our patient did have acute kidney injury, there were no electrolyte disturbances, urine output was adequate, so this also considered less appropriate. Hepatic formula, the patient did not have any advanced liver disease, so this formula again would be less appropriate. The same applies to pulmonary formula. And on top of that, don't forget that disease-specific formulas are much more expensive compared to the standard formulas. Now, from all of this, you can see that the standard formula was the most appropriate formula for our patient, and that's what we picked at the time. So far, we have decided it is the right time to start nutrition our patient. We picked enteral over parenteral, and we picked the standard formula for enteral nutrition. So what is next? That brings us to the fourth question. How much of this enteral nutrition and free water needed to be given? Usually we calculate the patient's 24 hours requirement based on that critically ill patients in general require the following. They require 25 kilocalories per kg per day, 1.5 gram protein per kg per day, and roughly 1 ml per kilocalorie per day of free water. As you see, all these calculations require the patient weight and height. So you have to get the actual body weight for all these patients. Admission weight is a good one to use. Now, use the ideal body weight if the patient's BMI is normal or overweight, and if the patient's BMI is underweight, use the actual body weight. Once we calculate the patient's daily need and choose the formula, it should be easy to calculate how much of the chosen formula the patient will need in 24 hours and how much free water we need to give as well. Let me show you an example of how to calculate this. Now we finished our calculations. Our patient will be given roughly 1560 ml of isosource per day and 875 ml of free water per day. And that brings us to the next questions. How are we going to provide these amounts? Enteral nutrition can be given as a continuous infusion or intermittently as a bolus feeding. In critically ill patients, we almost always use the continuous infusion way to provide enteral nutrition. With water now, we either give it continuously or intermittently through flushes every 4 to 6 hours. I usually give it every 4 to 6 hours through the OG tube or NG tube. Another issue with enteral nutrition is, should we start right at the goal rate, which is the 65 ml per hour in our patient, or should we start at a slower rate? It's very important to understand now in practice, it is generally considered acceptable that enteral feeding is initiated in critically ill patients at a rate of 10 to 30 ml per hour, or roughly at 25% of the goal rate, this is what we call trophic or trickle feeding, for 5 to 7 days, and then after that incrementally increase to the target or goal rate. So my final order will look like this. Now, if you are tired and don't want to make any calculations, just start the trophic or trickle tube feeds and leave the rest to the day team, or leave a consult to the dietitian in the morning. So you will not be wrong if you start at 20 or 30 cc an hour and just leave it there. Now, we have initiated tube feeding in our patient. How do we monitor that? Once tube feeding started, we should evaluate and examine our patient on a daily basis, specifically examining their abdomen for the following. Make sure their abdomen is still soft and check if there is any distension or any sign that would suggest an acute abdomen like viscous perforation that can be caused by the presence of NG tube or OG tube. If the abdomen is rigid, I will immediately halt tube feeds until acute abdomen is ruled out, especially to rule out a perforated organ or viscous. Same applies for abdominal distension. I halt tube feeds right away until bowel obstruction or ileus is ruled out. Also, examine your patient for any signs of fluid overload. In such case, we may need to use diuretics and switch to calorie-dense formula. Also, daily confirm the correct NG tube or OG tube placement. I always look at the chest X-ray to make sure it is still in the right position, or at least I can see it is below the diaphragm. Watch for any significant diarrhea or constipation. In case of diarrhea, we need to stop all stool softeners and laxatives, and we may need to switch to a fiber supplemented formula. And in case of constipation, we can add more laxative if needed, as long as their abdominal exam remained benign. Watch for vomiting, and if vomiting developed, we halt tube feeding. I usually give metoclopramide, Reglan, and restart tube feeding once vomiting is under control. And remember, the abdomen exam remained benign. Review the patient labs and watch for any electrolyte disturbances, especially if there is a risk of refeeding syndrome in some patients, especially malnourished patients. In such case, we need to aggressively replenish electrolytes and consult the dietitian if needed to adjust the formula. Pay special attention to hypo or hypernatremia. If hyponatremia develops, please decrease or stop water flushes. If hypernatremia develops, then we need to increase the free water flushes. Now, this is important. Please do not check for what we call the gastric residual volume. Nurses usually call it tube feed residuals. Basically, they check how much tube feeding can be sucked from the stomach through the NG tube or OG tube. They use this amount as an indication of gastric motility. It was initially thought it correlates with the risk of aspiration. We used to look at this amount, and if it is double the goal rate, we hold the tube feeds for 2 hours, then resume tube feeds, and sometimes we use what we call prokinetics like metoclopramide or erythromycin to enhance gut motility. Now, all of this is not valid anymore. Gastric residual volume correlates poorly with the risk of aspiration, so please do not do it. Now, some ICUs still have the practice of doing this residual volume, so simply try to reach to the ICU director and explain why they should stop such practice. If a nurse approaches you with this concern, try to explain to him or her that you are not worried and explain why you are not worried. If the nurse insists to do something about it, just tell them to hold tube feeds for 2 hours, then resume it without rechecking the residual volume before restarting the tube feeds. Please refrain from giving any prokinetics. Let's finish this video by giving you an idea how in real life these patients receiving nutrition looks like in ICU. When I run on these patients, I usually start by reviewing the patient labs. I pay attention to everything, especially for sodium and potassium. Then I look at the patient's chest x-ray. Remember, most of these patients are intubated. I make sure all devices are in correct positions, including the NG tube or OG tube. Please refer to my nasogastric tube video series on how to confirm the correct position. A link to those videos will be provided in the description field. Then next I go and find the patient's nurse and ask her for any overnight events. And for those receiving nutrition, I specifically ask about their bowel movements, if any vomiting, if any issues using the NG tube or the OG tube. Then I go see the patient with the nurse, and you will see these patients' heads are usually elevated by 30 to 45 degrees to minimize the risk of aspiration. I make sure I examine their abdomen, making sure it is soft. I look if there is any distension. I also look for any signs of fluid overloads like peripheral edema or scrotal edema. I hope you found everything you were looking for in this long video. If you found this video useful, please give it a like, share it with your colleagues, and don't forget to subscribe to our channel if you have not done so. I'll see you next video.